We're going to go through the in sequence fully guided prosthetic kit as it has arrived to Dr. Jurman's office, and we've removed the components, laid them all out, and we're going to do a review of each one, talk about the specifics and nuances of each one. We're going to start with what's called the start bite, and the start bite is the lab's fabricated replica of the bite that's received by whether it was the surgeon or the restorative doctor that took the actual bite of the patient. This is a replica of that. So the first thing we're going to do is the start bite. You'll see that because there's some edentulous areas on the patient, we'll have some occlusal stops to help keep that in proper position. The start bite is going to be always very thin. So you'll have to hold this in position when the patient actually is occluding into it. We don't want to have it too thick and have an interference when the patient goes into closure. So this will be before the patient is sedated, with the patient sitting upright, and we're just looking to see how the patient's articulating into this start bite. If they're hitting perfectly into it, the indication would be that if everything else goes well in the surgery, you shouldn't really have very little, if no, occlusal adjustments needed to the provisional. Some patients don't have repeatable centrics, and you may find yourself needing to do a little more adjustments. This is just an indicator. It's not a go, no go. It just will tell you what you can kind of expect as far as the occlusion. After the start bite was confirmed, then doctor would complete the extractions, reflect the tissue. Then the next thing would be to place the surgical guide. So this is a maxillary case. The surgical guide also comes with, there'll be 3 of these plastic pins to retain this. And you'll see all that when we go into the clinical applications of it. The surgical guide, it's going to have implant site numbers on it. The blue lines represent a stopping position for the clinician of where to put a flat or the dots of the placement mount. Whichever implant system you're using, there's going to be some indicator of where an internal flat or some have lobes, but where an internal flat is. So we're always going to do our angle correction pre-done because we've already ordered the multi-unit angled abutments, or the SRA abutments, based on the implant system for the angle correction. So it's important that these marks are followed during the surgery. So that's the surgical guide. Once the implants have been placed, the surgical guide will be removed, and then the next step when you do have angled is you're going to utilize the angle rotation guide. The angle rotation guide is going to literally take and bring the line of where the screw head is to line up for correct angulation. So there's 6 different positions on some systems at 60 degrees each position, and only one is correct. So this guide is going to help you to know that you line up the head of the screw, the abutment screw that goes into the implant, to that blue line, and that will give this perpendicular position. So that's what the angle rotation guide is used for. And you will notice too that these all have slots in them that once we get this is the bone foundation guide, we'll get to that in a moment. But once this is seated, there are female slots here so that these fit in kind of like Legos almost, and it'll be nice and flush here. That way you know everything is seated properly. So once again, that was the angle rotation guide, and you only have that when you do have implants that are being angularly positioned. Once the abutments have been placed, then the next thing is going to seat the temporary copings, and each implant site, there'll be a crown box, and in the crown box you'll have 2 of these temporary copings. For the Straumann system, it's called an SRA abutment. They can be straight, 17 degree or 30 degree. And then we'll have 2 of these small coping screws and 2 blackout plugs, and that's for each implant site. So then once the SRA abutments have been seated, the temporary copings then would seat on top of that, and you'll see all this in the clinical application. The next step will be to place what we call the tissue gasket. And the tissue gasket is a silicone. It'll act as a rubber dam, but it also will help to guide the provisional into proper rotational position, canter, and the occlusion. And once again, this fits right into the bone foundation guide. Completely sealing around the temporary copings would protrude through that. Then we're going to lute the prosthesis. We're going to utilize the bite guide, the prosthetic bite, and this would be for the patient to close into, and this holds the provisional in the proper position, and it also seals off the occlusal, and then the injection holes would be utilized to inject the bisacryl, the self-care acrylic material, luting the temporary copings to the provisional. So this is the provisional, the long-term provisional that would be utilized for the patient that we're going to actually be luting the temporary copings to. And as I previously mentioned, that the tissue gasket, when you have the tissue gasket seated in the bone foundation guide with the temporary copings protruding through that, this fits in and it has a perfect fit into that, so there's no rotation. And then we do have the injection holes here, a small hole for the vent and then a larger hole for the injection for each implant site. So we're going to take a look at getting familiar with the model itself. And what we mean by that is we've already at the laboratory, in Sequence Laboratory, we've already done the surgery. We placed the implants to the right depth, the rotational position based upon doctor's preference from the go-to meeting. We fabricated this 3D printed model. We have a line here that shows where the bone foundation guide is going to fit. So this line, the surgeon needs to reflect tissue beyond that line. And what I've done here is there's 3 areas usually on a model where the bone reduction, represents how much bone reduction. This one's very minimal in this case, so there's only 2 little pieces of it. But this is how much bone the surgeon will need to reduce. And so what we do is it's hard sometimes to see these clear plastics under the lights in the operatory. So we just outline the little black, the pegs on it, and then where they fit in, so that it's very easy to reference when you're placing the components in the other room. So now what we're going to do is we want to get familiar with how this is the bone foundation guide, this is the monostrut. These 2 pieces together are keyed also into the palatal area here, and they are held together with these little plastic pins. And these are the same pins that are used for the surgical guide. And so what we want to do is we want to seat, with the bone cut model in place, we want to seat the bone foundation guide, the monostrut, onto the model. And then we want to look to see where are we making contact onto the alveolar ridge. Not always do you have contact everywhere, but we want to note it. Sometimes there's be some interdental bone that might be touching this strut here, the antegalo surface of this monostrut. So what we've done is if you can see the little black marks there, we've made an indication, said yes, it touches here and it touches there. Oh, we got a spot, it touches along here. And then on this side here, on the patient's upper left, we've got just a point of bone touching here. So we'll identify that, and then what we'll do is we'll take a Sharpie and then highlight that. So that black will really show up in the mouth much easier to see. It just helps identify that you have it seated. This seating into the mouth isn't a matter of being just firm and not rotating. It doesn't mean it's seated properly. It needs to be that, plus it needs to be seated completely. The next thing we're going to do is we're going to take a look at how the bone foundation guide is adapted to the buccal and palatal walls, or buccal lingual walls if you're doing a lower. So we put the guide on here, and what we're looking for is there's spaces where there's gaps between the buccal plate, the buccal wall of the arch, and the internal wall of the bone foundation guide. Those gaps are caused because of the trajectory of the bone for path of insertion. So there's gaps, but there's also places that are making contact. So what we're wanting to do is I've taken a Sharpie and just dotted areas that, yep, we're making firm contact in this area, we're contacting right here, we're back here, and even palatal, we like to mark where we're seeing marks here. So now that we know when we're in the mouth that if we see this contacting bone here, and then we come back and put the monostrut on, and we see the contacts that we're getting underneath here, then we're ready, we know we're ready to go ahead and pin this with the horizontal anchor pins and secure this, bone secure, and begin the procedure. So that's our getting familiar with the models, reviewing the components, and this usually should happen a day at least before the surgery. Okay, so we're going to add Vaseline now to the prosthesis to make cleanup easier. And we want to get the occlusal. Anywhere there's pink, we want to get the integral surface. And we're going to come with a Q-tip, and we want to clean out. We don't want Vaseline into these areas. So what we want to do is we want to come from the inside, and we want to just blow out any of the acrylic that might be in those little holes. So we blow from the inside out, a little Vaseline, not acrylic. There, now we're ready to place this. All right, so what we're doing just came out of the mouth. We haven't done anything yet. So there's 3 areas that we need to evaluate here that we need to address. The integral surface, we need to flow in the negative areas here. The tissue gasket acted as that rubber dam. So we're going to backfill into here around these, make them nice and hygienic. Then the other is the buccal area where those injection hole and vents were. We want to make sure we've got those all plugged, so we're going to evaluate that. So it's 1 is integral, 2 is the buccal surface, 3 is the occlusal surface. So obviously we're going to do some grinding here to get a little bit of this bulk out of here, and we're going to backfill into here. And here, as far as the occlusal, we're going to be taking a new bite with this. So what we don't want is just want to make sure the material is out of the way. So all I'm going to do is I'll flow in where I need to backfill for strength, but this is great. Everything was done very nicely here. We haven't added anything yet. So this will probably just take a burr and smooth that so it's comfortable with the patient's tongue. This will be used on the first restorative appointment. You're going to use this to capture the patient's final impression, final bite adjustment, and then any aesthetic changes you want, just make a note on this as if this was a wax try-in. So what we're doing now, I mentioned that we had the 3 areas to address that we have to do is the integral surface, the buccal injection and vent holes, and the occlusal. Right, so we went ahead and flowed around the negative areas here with just some Bisacryl Instatemp material. You can use Luxitemp, ProTemp, a lot of different materials. And this is untouched. So I just flowed around and I took my finger and just kind of wiped that smooth. And I did the anterior one here and I did one over here. What we've done up here is I sometimes will just take these are just the Q-tips, the cotton swabs, break them off, put a light coat of Vaseline on them because the texture of the wood, the acrylic might stick. I like this sometimes because they're nice and tall. but I want to backfill and syringe in areas that we need to, and I don't want to get any material into the cylinder holes. So here's one I've already done, so you can see how perfect that little hole is there. And I've done this one, I haven't removed this yet. So if I take this, give it a couple of turns, and now I remove that, and you can see we have a perfect, we got a shaped tooth. We just need to kind of clean it up. A little bit of a little high in the occlusal, so we'll flatten that down. We can adjust that in the mouth. And so I'll go ahead and do the antegular surface right here. I like to always express a little bit out here. And when you're trying to fill, just put the tip down in. It's kind of like just painting the material in. You want to come, there's a ledge, a collar, if you will, on these. And I'm doing just wiping it smooth. That one's ready to set. So it's hygienic, it's not going to be traps there. Turn over. Come in here. Because I blocked that hole, I can go and start shaping around the tooth here. Fill in the back side of that one, so we have a nice strength behind that tooth. That'll grind real fast and easy. They'll come off real clean and easy, no worries there. I just want to make sure I have material to work with, because at the burr, I can make these adjustments very easily. So even though it looks kind of rough, you'll see how quickly I'll be able to take that once that sets up. So we've got the antegular surface finished off, just ready for polishing. What we have left are our little buckle holes here. So chairside material, they have a nice little extra tip that comes onto a fine tip, which you want that for control. And so I'm just going to come in here, feel like a little teardrop, give me a little something just to take a burr and a rubber point real quick, just to hit that, to finalize that. And we have a little bit we need to add right in here. Okay, so now we're ready to go ahead and finish everything. So we've sealed off our buckles, we've sealed off and contoured the antegular surface, and we've backfilled here. So I'm just going to remove my plugs. And I like to just get an acrylic burr. Now I start redefining the anatomy here. All I'm really doing is I'm blending this for patient's comfort for the contour. We'll finish up with a rubber point. So we know we have some high points here. We'll get the final occlusion adjusted in the mouth. I'm just making sure we don't have anything sharp for the patient's tongue. Robinson Stiff Bristle Brush. And I like this. This is their shorter one. They have longer ones, but I like the shorter one. It's pretty stiff, but watch how it works with the around these bases here. It will. You just take it in like a circular motion, but I'm just blending, coming from the base up onto it. And I can keep a nice ledge, and I can really actually kind of shine it and almost polishing as I go here. Now it will cut, so you don't want to be too aggressive on that. But I can put it onto the metal and get any flash. It's not going to damage that collar at all. If you can see how that collar is shining, get nice and shiny. And all I'm doing is just blending and tapering. I mean, there's no burr taking that at all. So there it is. That one is all finished up there.
Hi, I'm Dr. Jurman, Dave Jurman from Plainview, Massapequa, Levittown Oral Surgery, and this is...
My name is Keith Williams. I'm with Straumann Dental Implants, and I'm the area manager for New York. So today we completed a full arch case in partnership with InSequence and the group here at Plainview, Massapequa, Levittown Oral Surgery, and we utilized our newest implant, the BLX implant. This implant was designed specifically for these cases. So
depending on the bone quality, I could have the flexibility of under-prepping the osteotomies, so it helps me really to engage the bone and give me that primary stability that we need for these full load, medial load cases.
So we started doing full arch immediate load cases with our BLT implant, and when BLX came out, it was just natural to switch over to BLX. It's more of an aggressively threaded implant. It gives you higher primary stability, but it also gives you one platform restoratively to work off of, but a range of sizes. So you can go from a narrow diameter implant like 3.5 up to a 6.5 diameter implant. So you can accommodate whatever bone width you have, but still have the predictability for our restorative partners. You also get the SL active surface with the BLX implant, so you get integration times in 3 to 4 weeks. That's backed by over 10 years of science. I'm always here to support the cases, and we always have all the parts and pieces on hand, and using digital workflows that we've started to incorporate with scanners, printers, and planning software. These cases are really becoming, I would say, the norm, and also clinical outcomes are at an all-time high.